So again, I'm Dr. Jean-Luc Urbain. I'm a professor of diagnostic imaging at the University of Western Ontario, and I'm also a professor of molecular biology at Temple University in Philadelphia. What I like to do is basically take you a little bit through a journey. Over the past, I would say, 10 years or so, I had two major interests. One is molecular biology and molecular imaging, and the other one, since I came to Ontario, I was forced also to look at the socio-economics of healthcare. And you'll see through these slides that neuroendocrine tumor is actually a perfect case study for personalized medicine, particularly as it relates to nuclear medicine. Now, if you think a little bit about it, and forget about the fact that you might be affected by a neuroendocrine tumor. If you go to your physician for any type of disease, even in this century, he will basically listen to your history. Hopefully he's a good doctor. He'll use a stethoscope. I'll do an EKG most of the time. I'll do a chest x-ray, and then I'll say, I need a little bit more information. So I need lab values, I need a CT, or I need an MR, I need an ultrasound, and I'll see you in 2 to 3 weeks. In the ideal cases, in Canada it might be a year, but that's a different story, and we'll come back to that. And then you come back and he sees you, and either you have recovered, or he's going to prescribe to you a treatment and say, I'll see you again. This is 20th century medicine. It's a very empirical type of medicine. Now, as Dr. Bohm said, in the 80s, Jean-Luc Urbain and the group from Krennings in Holland, and Lamberts actually was the endocrinologist, as the foresight to think that, well, somatostatin blocks most of the secretions in the body. Maybe you can use it for what was called at the time epidermis. And then at the time it was Labas, I don't think it was Sanofi. It was the precursor of Sanofi. I forgot exactly. Richard, maybe you remember. You're so much younger than I am that you should remember. I'm sorry? Yeah, that they thought that they could probably, since somatostatin was a small peptide, an hormone, and they could probably identify that part which would eventually bind to the cells. At the time, the notion of receptor was there, but was very unclear. And maybe they could use that small peptide, synthesize it, label it with an isotope, and maybe like magic identify those cells which were abnormal. So that's the concept of somatostatin scintigraphy. And this is a cartoon from the late 80s, early 90s. I was very privileged in life, and I was very privileged to practice at the time in Belgium, because there's a fair amount of studies which were done in Europe, and particularly in my center. And that's the overall concept of basically octreotide scintigraphy. You have here, you have your compound, you have your peptide, and here you have your isotope, either for diagnosis and treatment. At the time, it was pure diagnosis, and in the very early days, actually, we were using iodine-123, nitrotechnetium, neoindium. And then we were generating this type of images, and we thought this stuff are phenomenal images. Another approach that people used to use is the concept that some of those cells are actually very active in the captation, storage, and secretion of adrenaline and noradrenaline. So maybe if we could label adrenaline or noradrenaline, maybe what we could do is use that for those tumors. And here, basically, what you see is this is a nerve cell, this is another nerve cell. In between, it's all kind of peptides and hormones. Noradrenaline and adrenaline has the ability to be stored into these cells over here, taken up, and then in due time, sometime at the appropriate time and sometime at the inappropriate time, be released here in between, bind to the cells, and induce some action there. And that's exactly what this compound, which is very close to noradrenaline and adrenaline, can do, is basically be stored into these cells here, and then be released. And we have used that basically to label those tumors which are an over number, which have an increased number of this type of cell, for example, ganglioma, paraganglioma. That's basically the background of and the origin of what I think is really molecular imaging. So late 80s, early 90s. And then with all the development in molecular biology, essentially in molecular oncology, what we started to realize is that we were looking at patients when they have developed symptoms, but we could eventually go back the ladder. Structural changes come pretty late in the disease, and as Dr. Boom said, this is definitely not a good way, at least not the ideal way, not an early way to look at neuroendocrine tumor. We also realized that if we wanted to be a little bit more proactive in diagnosing those tumors, maybe what we can do is look at the function, particularly neuroendocrine tumor, which usually you don't die of the aggressiveness of those tumors. You die, and as I said before, I might die too, of this type of disease, but you are affected because of the production, the functionality of these tumors and the dysfunctionality of these tissue. And the concept also came that, well, you know, secreting is one thing, but what's happening inside the cell before they are dysfunctional in their ability to secrete and not secrete product? And with the progress in molecular biology, it became also obvious that most disease, not all of them, but most of them have a genetic origin, and that the dysfunction of the cell can be traced down to some alteration at the genotype level. And I don't have to go too much over this slide. You know that neuroendocrine disease can be very complex. But what I would like you to remember is that there is a major overlapping of lesion in genetic syndrome. I have listed here MEN1, MEN2, pheochromocytoma, neuroendocrine tumor, and so on. Very difficult at the end of the day to predict on the genotype only what is causing what. And we're still learning every day. As Dr. Boom said, we're looking for genotypic signature. And that's a word which is used in the literature. In other words, nothing in molecular biology, like in life, is black and white. It's always some alteration, and we're still in the phase of understanding all that. Now, going back to the cartoon that I had presented before, going from the genetic abnormality to patient symptoms, we have developed a fair amount of tools. Clinical assessment, structural assessment, it's in the domain of radiology. Functional assessment, by definition, it's in the domain of nuclear medicine. And then if you do a biopsy, you do cytology, cytopathology. If you look at what's going on inside the cells, that's the phenotype essentially. You look essentially at signaling cascade. And that's a very important word, and I'll come back to that in a little bit. And then at the genetic level, everybody knows what DNA is. Everybody knows that we can run basically patient genomic profile on little chips, and we'll come back to that too. So In the mid-90s, starting in the mid-90s, basically a researcher decided, well, maybe it's time to switch our approach of neuroendocrine tumor from being very empirical and using octreotide towards what's happening, to what is octreotide binding on the surface of the cells. And in the early mid-90s, researcher demonstrated there is at least 6 types of somatostatin receptor. What we didn't know at the time is on which one somatostatin and octreotide was binding. Very complex. To make a long story short, octreotide is essentially binding to the type 2. And that also explains why we can never be sure, if we don't see anything with octreotide, that the patient might still not have a tumor, but the receptor, as Dr. Bohm was saying, and I love the expression, maybe the cell is expressing a different type of lock. Maybe it's your next door neighbor lock, and we don't have the proper key. And again, we'll come back to that. So out of this, switching into 21st century, here's a list. As Dr. Bohm says, Dr. Walker, name it the way you like. It's all kind of possibility here. And basically what this list is showing you, and as far as I'm concerned, you're welcome to have a copy of these slides. So you don't necessarily have to take notes. Basically what this list is showing you is the affinity, how well the peptide will enter the lock, or well the key will bind to the lock. And depending on the nature of the peptide, depending on the nature of the isotope that enables us to detect the cells and the tumor, it will tell you which peptide will work under which circumstances. Another very important aspect is that and that might be a little confusing to you, is the NETs concept. It had nothing to do with neuroendocrine tumor. It's the norepinephrine transporter. It's like glucose. In order to get inside the cells, basically adrenaline, noradrenaline, same thing as epinephrine, norepinephrine, use transporter. They are carried inside the cells. So we have identified at least 1 or 2 of these transporters. Very important to know if you have these transporters expressed at the surface of the cell. When Dr. Reed, Dr. Buscom, Dr. Broom, and the others are telling you, well, we're treating with MIBG, that's because they have shown that the patient has this type of receptor. When he's telling you, I'm treating with octreotide, it means that the patient has somatostatin receptor on the surface. And hopefully, both type of receptor are expressed, and they can use both type of weapons. Usually, and what you have to remember, cancer cells are very, very difficult to pin down. They like viruses. They like the flu virus. They mutate all the time. And unfortunately, when the disease advances, basically those cells usually do not express the somatostatin receptor nor the noradrenergic receptor. And that's when, in the future, monoclonal antibody can play a role. But that might be for another talk. This is basically summarizing a little bit what's happening inside the cells and at the surface of the cells. The way to see a cancer cells is basically like your car, at least in North America, when you have the gas pedal and you have the brake, no clutch in North America. All right? So if at one point in time you push the gas pedal totally down to the floor, basically you cannot control your car. I never tried, and I don't recommend that either. But at the other hand, we always have a brake mechanism. It could be inertia in the case of a car, which tells the car, well, slow down a little bit here. There's no need to go that fast. That's the concept of oncogenes, which are genes which tell the cell divide, multiply, and tumor suppression genes, which are telling the cell, hey, wait a second here. I don't need you to divide like this. I don't need you to multiply. Quiet down. The balance, and I should say the unbalance between the two types of gene decide if a cell is going to be cancer and not cancer. And depending on the type of cancer that you have, you'll find very specific oncogene or tumor suppressor gene. expressed or not expressed. And that's exactly what this slide is showing. Now, remember also that cells have a membrane, and the interaction between the cells and the neighbors and neighborhood environment is basically the membrane. So you have locks at the surface of the membrane. Now, in order for the cells to carry its job, even cancer cells, before they became cancer, hopefully they were carrying some useful jobs. Basically, you need to transfer the message, you need to translate the message from the surface of the cell down to the nucleus, which is the core of the cell. In between, you find different relays, different paths. That's what's called the signaling cascade of the cell. This is one of a gene, by definition, is responsible for the synthesis of a protein, and that protein can be a receptor. And for example, the RET-TK receptor, the RET-TK gene is known to be able to trigger neuroendocrine tumor. Same type as this gene here. Same as this one here too. So different signaling pathways. Now, over the past 10-15 years, the clinicians have developed a fair amount of tools to treat genetic diseases using gene therapy, stem cell therapy, or what's called the signaling cascade inhibitors or activators. So in other words, if the cell for some reason is embarking into a totally uncontrolled journey, maybe you can go inside the cells and block that journey. Or reversely, if the cells cannot stop the tumor suppressor gene underactive, in some instances you can activate those tumor suppressor genes. Dr. Bohm mentioned that PETs and nuclear medicine are a very good way to look at the efficacy of treatment. I love this slide. This is basically, it's not a neuroendocrine tumor. It's actually from my friend Dominique van den Nabel at the Dana-Farber in Boston. Basically, what this slide shows is this. So this is a patient with a tumor, multiple metastases in the abdomen. This is the PET scanner before any type of treatment. This is the CT before any type of treatment. And then the patient takes one single pill. In this instance, it's Gleevec, which is tyrosine kinase inhibitor. And look at what's happening. Most tumor, it shuts down the uptake of glucose by most cell. By 7 days, a dramatic effect. But it takes at least 3 months to show any difference in terms of the structure of the tumor. Now, if you read Scientific American, there's usually a very good article in there. You don't have to be a molecular biologist. A year or two ago, what they published is that the Human Genome Project is way over. What's current now is the Personal Genome Project, led by Harvard. And they anticipate that by 2014, for $1,000, they will be able to sequence everybody's genome. What it means is that by comparing your genome with a pool of, between quotes, normal, who knows? I used to tell my resident, only God knows what normal is. Basically, we'll have the marker, we'll have the biomarkers available. And the concept of personalized medicine is to be able to predict who is going to develop disease, eventually to prevent it, and then, if we were not able to predict or prevent, to detect the disease, to pinpoint exactly where the disease is in the body, to treat that disease, and to follow up this disease. This is molecular medicine and personalized medicine too. Now, who is President of the United States? Who doesn't know who's the President of the United States? George Bush, right? Okay, well, in 2006, Barack Obama introduced a bill to the Senate. What was striking to him is the side effect after taking medications. So the bill that he introduced hasn't been voted and enacted during his tenure at the Senate, but will be enacted very soon, is the concept of personalized medicine, where basically the industry, in order to develop any therapeutic compound, must develop an assay, a test, to demonstrate that first the patient needs that medication, that medication is sufficient and doesn't have a lot of side effect. That's personalized medicine. And you'll find on multiple websites the concept of personalized healthcare too, describing very active. There's actually a personalized medicine coalition in the United States, which has a fair amount of resources. So if you translate what I just said into the neuroendocrine disease business, basically the ideal for us is to be able in 2009 to detect this type of abnormal cells, be it from the gut or be it from the brain, whatever. And then I would say in the ideal world, we would be able to detect these cancer cells. We will be able to look at the expression of the different gene, the different receptor, and I would say within a few hours, we should be able to select those peptides, those monoclonal antibodies, microbodies, diabodies. Here is an example on affibodies, which is a very specific concept. We'll be able to label them and inject that to the patient, pinpoint where the tumor is, and use the same compound to treat those patients with atrium or with lutetium. This is personalized medicine for neuroendocrine tumor. Before we do that, we will have to do animal models. Now, the problem that we face in Canada, but it's true also in the rest of the world, and particularly in Ontario, is this. The problem that physicians have, referring physician, clinician, everybody, is that symptoms are largely non-specific. Who never had any diarrhea in his or her life? We need to make a diagnosis. If a patient has symptoms, we need to know where the symptoms are coming from. And also, we need to know how far advanced the disease, whatever the disease is at, so we can fine-tune the treatment. But also, we need to monitor the treatment. So there is a huge requirement, a huge pressure for the physician to basically diagnose the disease and follow up the efficacy of the treatment. Now, looking at Ontario, so we're becoming a little bit more personal here, but looking at Ontario, people would tell you that medical imaging has grown exponentially in the past 30 years with the development of CT, ultrasound, MRI, nuclear medicine, and so on. And that it's not necessarily, those studies are not necessarily always useful. And those, what I call technocrats at the government level would tell you that one of the reasons why we do too many tests is many reasons. One is the increased reliance on technology instead of relying on fingers and stethoscope. But in the 21st century, I don't think it's still very adequate to rely on stethoscope only, for example. Reassuring the patient. In United States, healthcare is largely driven not only by money, but by lawsuits. So we request tests just to avoid lawsuits. Sometimes they're useful, sometimes they're not useful. So there's a lot of pressure to require a fair amount of tests. What I also would like you to remember is today is what, May 7? May 9. Okay, sorry. I didn't have enough sleep after 5 days of meeting. But today is May 9, 2009. Maybe next year or 5 years down the road, you'll reconvene here and you'll say, oh my God, Dr. Boom, what did he tell us? Obsolete. And it's only 5 years down the road. If you look at these curves, and people on the government level, regulatory level knows that very well. You can invest as much as you can into a technology. At one point in time, you'll reach a plateau. And in other words, you have yield. You have taken, the technology has given you as much as it could. And it's not helpful to invest more money into this type of technology. You need to shift gear. And one of the reasons is this. Look at the expenditure which is done in the United States, the UK, and Australia per capita to achieve basically pretty much the same life expectancy. So there is a lot of question there that we need to answer. We need to spend $4,000, $4,600 to achieve the same life expectancy as in the UK or in Australia. So probably the system is inefficient. Now, if you look at, for example, in Ontario, what the regulator there would tell you is that over the past 12 years, I think they started their measurement 94, 95 up to 2004, 2005. Basically, the MRI utilization has grown by a factor of 6, CT by a factor of 3, and it's ramping up. I was talking to a former politician in Ontario who was telling me that the difficulty of the Minister of Ontario when they sit down together is that they're always looking at the Minister of Health and tell him, you are using 47% of the budget here in Ontario and you are growing at 2%. What's left for others? So we have definitely a major problem in terms of utilization. So more and more, what you're going to see is the regulator, those in charge of the healthcare system, asking us for accountability. And one way to ask us for accountability is to really prove that what we do is useful. So that's the reason why, be it Health Canada or Ontario and the others, they are putting in place mechanisms and forcing us to go through steps demonstrating that technical efficacy, diagnostic accuracy, referring to the bias theorem, for example. And then, when we have proven that our diagnostic procedures are useful, is that really changing the outcome of patient? Not only the quality of life, but I showed you, is it changing life expectancy? We will have to answer those questions. Not only the physician. We cannot answer those questions by ourselves. We need biostatisticians. We need epidemiologists. We need economists. We need quality of life experts, and you are the right group to talk about quality of life. We need scientist decision, and we also need health policy experts. So it's a joint effort in order to accomplish that. That's also the reason why it costs so much money for the industry to develop new diagnostic agent, new contrast agent, and new medication. Now, to give you an idea, put a number on the table, look at what the expectations are in terms of therapeutic pharmaceutical in the United States. 2005, 57 million. Projection in 2012 is $1.9 billion. So even with this type of money, the industry would tell you that they have very little reason to develop new contrast agent, new pharmaceutical. It costs more than $1 billion to take a product very early on, to identify a product and to carry it to phase 4. More than $1 billion. So there might not be enough resources in the system. A former friend of mine who works at Bracco, I think summarized extremely well what the challenge that we have here. Basically what he's saying in this slides, and once again I can have a copy of this, is that we're going to have to sit down around the table with all the players, all the stakeholders, and try to make it easier, safer, and eventually cheaper. Now, when I hear the story through Jim, to Maureen, to other patients, I'm literally shocked. I'm shocked to see what I'm seeing in Canada. And the reason is my understanding of the Canada Health Act is that care should be free and should be available to everybody. Now, at the federal level, it's somewhat a little complicated, but basically you have the Minister of Health and then you have different departments. And as I said, we're lucky to have Agnès Klein. She does not necessarily speak on behalf of Health Canada. She speaks on behalf of her own, she can speak on behalf of her own division. But this is to give you an idea of the layer of what we call bureaucracy, but sometimes bureaucracy is needed. What we have to do actually, and I was so stunned that most of the time patients are not aware of that, and to some extent even physicians are not aware of that, is that the way to see the healthcare in Canada is that at the federal level is regulation. At the provincial level, the provinces are responsible for the delivery of care. So they are accountable for the delivery of care, but they're not necessarily regulating what's needed in order to carry it. And even more now, there is another layer, particularly in Ontario. They just got rid of that approach in Alberta. They're creating in Ontario. It's the concept of regionalization of healthcare. It's the local integrated, Chris, help me here. The LIN. Yeah, it's the local integrated, thank you, which has up another layer of bureaucracy. And with the current financial environment, I love the expression of Jim, basically what each hospital is looking at. In Ontario, if the CEO, a few years ago, I think it was 2005, the CEO and the board of directors signed an agreement. Each hospital had to do that. They signed an agreement with the Ministry of Health that they would be accountable if they would not respect their budget. So if they would go over the budget, and the penalty is that they can go to jail. So whole hospital in Ontario are looking to cut whatever program they can cut. It's not needed. So we have reached a point now for a disease like the neuroendocrine tumor disease in London, where basically the delivery of care for neuroendocrine tumor is done by postal code. So in other words, if you're out of LIN 1 and LIN 2, forget it. You're not welcome. And I was talking early on to a lady from Manitoba. The hospital doesn't accept anybody out of the LIN 1 and LIN 2 at this point in time, even if their province is paying. So there is a fair amount of issue, there is a fair amount of barrier which needs to be addressed. Now, Health Canada always seems to us very slow, ultra-conservative, but there is a lot of work going on behind the scene. And I'm now part of a committee looking at a specific class of tracers called the positron-emitting radiopharmaceutical. Not necessarily gallium-68, for research purposes. And the government is engaging basically the stakeholder to discuss and see how that we can expedite the development of these drugs and their availability eventually on the market at one point in time. Now, in order to accomplish what we want to accomplish, what you heard over the past during the course of the day, physicians like Richard Boom, John, myself, and the other, we just cannot do it ourselves. We need molecular biologists to help us. We need the industry to help us. We need the IT people to help us. We need basically the entire healthcare system to help us to carry that. And we also have to do that in a very financially responsible manner. Remember, there's no money, no care. That's very simple. No exception. One of the reasons why I'm here today is that over the past month I had the opportunity to interact many times with Jim, and I feel really bad. I feel really good and really bad at the same time. I feel really bad because I feel that at every single level of the government, be it regional, provincial, or federal, patients are being let down. At the same time, I feel really good because suddenly, at times we get depressed as physicians, particularly when we don't have the tool to diagnose and treat patients. But I feel really good and I feel energized. And I felt probably I had more energy over the past month or two since I met Jim than over the past 5 years. Because to some extent, I see the light at the end of the tunnel. And the light at the end of the tunnel is you. You are the reason why I, Rich, John and the others, got involved into medicine. Richard mentioned to you early on that he was really moved and taken by that young boy. Well, so am I. So that's the reason why people like us want to help. And what we are trying to fight is this, particularly in Canada. So you have cancer. Hurry up to a physician. Hurry up to get a test. But sorry, it's going to take 6 months to a year to get you a test, and maybe even more to get treated. So in order to accomplish and to fight this and to achieve what you want to achieve, what we want to achieve, we're going to have basically to collaborate and consolidate our effort. Thank you very much.